Good afternoon, everyone. We just got the final session for the day, so a big thank you to everyone for being here today. It's been a huge success, and I hope everybody's enjoyed it as much as we all have in terms of sharing the great work that happens here. Can I just start by acknowledging the traditional custodians lands on which we stand? We're on Wurundjeri land of Kulin Nation, and pay respect to elders both past, present and emerging, and extend that acknowledgement to any First Nation or Aboriginal and Torres Strait Islander in the room. So we've got a panel discussion of key experts here. We've had a really good, I think, showcase of the data that we talked about around that comes through the National Addiction and Mental Health Surveillance Unit, the NAS data, and Rowan can give us a bit more of a history on that. But really, we've got a fantastic panel of essentially people who put that data into practice, so the policy implications of that data. So I'll just briefly go through the panel just to introduce you. So Rowan, you've already met. He's acting strategic lead for the National Ambulance Addiction and Mental Health Surveillance Unit. We have a late arrival, Chris, who came all the way down from Canberra to appear on this panel, didn't you, Chris? So Chris is a long-time friend of the NAS data, in fact, a long-time friend of the original Victorian data and been a big advocate, and I might ask you a bit about that as we go. Chris is head of the Suicide and Self-Harm Monitoring Unit at the Australian Institute of Health and Welfare. He's more than 20 years experience in the development of health policy and evidence in both the Commonwealth and ACT governments. His areas of specialisation include suicide prevention policy, mental health policy, alcohol and the drug policy, and the use of data and evidence to inform government decision-making. And Chris is really going to share his insights today around how we make impact. Our next panel member is David Taylor. So David is the Policy and Media Officer at the Victorian Alcohol and Drug Association, so VAADA, the peak organisation here in Victoria that leads alcohol, drug policy, workforce development, and policy discussions across the sector and across Victoria. David has coordinated VAADA's advocacy activities and has previously worked in community legal services as well as at TAFE and in university teaching roles. And Dave, again, is a big a fan of the data we hold here and how to use that, and we'll be asking him around his thoughts on that data and how best to use it. And our final panel member is Amy Herbert. So Amy, again, we've already got fans here of our data, by the way. We couldn't find anyone who wasn't. That's right. So Amy is manager of the Alcohol and Drug Strategy branch in the Department of Health. She is a lawyer by training and has worked in legal, social and health policy for 14 years. Amy's collaboration with Turning Point has been instrumental in driving forward a joint effort to address the treatment, specialist care and support requirement of those affected by addiction. She holds the research and policy portfolio at the department and keeps us honest and makes sure that we do great work for the sector and for the community. So let me just start by asking you a question, Rowan. Can you just, you mentioned it there, obviously you only had 8 minutes to cover your whole presentation. So maybe if you just give us a bit of a history of sort of where the ambulance data sets come from, where it's at now, and sort of some of your thoughts of sort of where next.
Yeah, thanks, Dan. And maybe I'll keep this to another whole 8 minutes to go through. Is that all right? Yeah, so the National Ambulance Surveillance System started as kind of a localised project, and it was centred around parts of metropolitan Melbourne in the mid to late 1990s during the heroin glut, where there was big community concern about overdoses occurring in local communities, and there was no way to monitor non-fatal harms at that time, even though there was a huge service burden. So Professor Paul Dietz, who couldn't join us today, did set up the system. And since then, it's really grown in breadth, that it's expanded out to all alcohol and drug, and then all of Melbourne, all of Victoria, and then other states. And as I mentioned in the talk this afternoon, also in depth in terms of the number of outcomes. But perhaps adding to that, I think it's grown in impact. And we can look at impact in a number of ways. We can look at impact in the number of cases that were coded, and we're up to 1 million projected this year, almost double what's happening 3 or 4 years ago. So there's a significant proportion of the population seeking help through ambulance for AOD and mental health care. And I'd like the other speakers to comment on that too when they get the chance, because I think that shows the value of the data set. Where to next? There's so many opportunities, and I think we've had wonderful presentations from Naomi, Anthony, and Krista to show the value of identifying vulnerable groups. And that really ties, to me, this symposium together. We heard about it from a consumer perspective. We heard about it in a clinical trial perspective in the morning. And big data, as Bosco mentioned as the previous chair, can play a role there. We can hone in, identify vulnerable groups, and say, what's going on for the individual, what's going on for the system.
Thanks, Rowan. I might just throw to Amy. So Amy, obviously the data set started in Victoria, and Paul Smith, who used to run the department, Chris would know this, when we were trying to expand the data set, he said that it's the brilliant data set that you never want, because once you have it, you can't unsee what it shows. Can you just talk a bit about your sort of reflections on the data set and how it's been used sort of within your branch?
Yeah, sure. So I work in an area that does AAD strategy and policy. So we sort of inform decision makers around investment, new policy ideas, that kind of thing. And I think this type of data is one of those really good examples of that rule around count once, use often. The idea being, you find the greatest kind of, the widest possible data set, and you work out really great ways of using it to lots of different effects. So the idea of kind of having this one really useful data set around people arriving in crisis and in need of a bunch of different interventions is really good. So, in terms of what we use today's AMBO data for, yes, we use it for investment. There is not a business case that goes up to government that doesn't use information collected through this data set. So in that sense, every key sort of investment decision that has been made, definitely since my time in the portfolio, or any significant new service like the MSIR, or different kind of policy approach like public intoxication reform, when we're talking about, different impact on, different cohorts, all of those decisions are directly using information that has been coded through this data. So it's really, really helpful. And I think, there's always, it doesn't get yet to that fine-grained and kind of rapid analysis that other data sets do, like, if we're getting tox samples or the like. But I think, even so, it does kind of contribute to those data sets just through triangulation. When we're sort of thinking, oh, is this a trend? What does this look like? It helps us sort of, check against if we get sort of some advice around, a dangerous new drug. So, for example, we get asked about fentanyl. And we're asked about service readiness, and if fentanyl expands, what would that look like in the local drug market? We can say, oh, well, you can see the prevalence of methamphetamine from this year to that year, and kind of say this is how quickly things can kind of expand in terms of the drug markets. So it's useful, those kind of long-term views on short-term issues.
Thanks, Amy. I might just go to Chris, because Chris, I suppose we first met in the Department of Health in Canberra when we're trying to take the alcohol drug data national. And I suppose my question to you is, what did you see that was that caught your eye around the data? And I know you've been a bit of advocate at expanding the data and taking it to include mental health, suicide, and self-harm. So can you just talk about what you think is unique about the data and why you've become such a big advocate of it?
Yeah, thanks. And I like the way you phrased that. We met over a Department of Health, yes. But I just
meeting place.
I just want to pick up on something that was mentioned in the local use of the data, and that is around looking at the non-fatal outcomes of some, be it suicidal behaviours or overdose behaviours. And given that we've been able to work with Turning Point to ingrain the National Ambulance Surveillance System within the broader National Suicide and Self-Harm Monitoring System, it forms a really important component. So we can look at the deaths data, but in the majority of places across Australia, we can't really get a good insight to what's happening in non-fatal behaviours, particularly around self-harm in hospitalisations, for example. But this gives us things that we can look at that we can't otherwise see. And I'll give you a very practical example. Over the beginning of the pandemic, there was a great deal of concern. People in this room probably remember some of the public discussion around the effects that people were anticipating might come from lockdown and the social prophylaxis that we put in place to reduce infections. And we were monitoring the coronial data very, very closely. And we were able to report to National Cabinet, and we were reporting on a weekly level to say, look, we're not actually seeing people turn up in the coroner's courts. So fatal behaviours are not accelerating. But we were able to look at what was happening, particularly with younger women. And it wasn't just in Victoria, it was around the country. And it was only because we had access to those data from the ambulance system that we were able to say, we're not out of the woods. It's not that everything's okay. We just have a different type of problem that we need to look at. And it was really useful to be able to draw that to the attention of ministers and help them build their responses to that.
So much, Chris. Moving to you, Dave. Obviously, VAADA has a huge role in sort of advocating and calling on improvements to the system. Can you just tell us of the way in which you use the data and the different ways in which the data is presented?
Sure. Look, we make a number of submissions to government. We present to parliamentarians. We provide briefings to parliamentarians. We do presentations at conference. We do presentations to the sector. We liaise with our colleagues in other sectors. And in all those activities, a lot of this data is pivotal in being able to put forward a case with regard to harms and so forth, which a lot of the folk experience. I guess, you know, one of the things I do realise looking at this data is, you know, looking at how people are counted varies depending on who's counting it. So we saw earlier this week, for instance, the Pennington annual overdose report listed the number of fatalities in Victoria in 2021 as about 420 something. Last year, the Victorian Coroner's Court put out the fatal overdose data in Victoria for the same year. That was 500. And I think if you look on AOD stats, there's a separate figure again, but that's counting where AOD is involved rather than you know, where there's toxicology. So the concern which I see with generally any sort of data source and is translating that into something which is comprehensible by the public and even by policymakers. And so people sort of can pick their winner in these sorts of things and cherry pick the data to suit whatever narrative they're setting. And one of the really unfortunate things I see with AOD is that, you know, it's fantastic to hear Amy and Chris talk about the data being used regularly and politicians taking it on board, is that in advocacy, what I've often seen is thresholds. And so AOD policy is generated by catastrophe. We don't get new policy until something awful happens. You only need to look abroad when you see evidence-informed harm reduction policies such as drug checking, increased consumption rooms and so forth. You know, you often see they're introduced through fentanyl and other such substances where the fatal overdose numbers add another zero to it, or the ambulance numbers increase and so forth. You know, it will be good to try to be able to count outcomes and positive outcomes and triangulate that in a way so we can actually sell our story in a way where there's a positive end to this and not simply just counting catastrophe and waiting for something disastrous to happen before we do something sensible.
I think I don't know what to say after that. It's it really, I suppose, speaks to sort of how we take the data to the next level and the importance of having, you know, data to constantly escalate and elevate. Just coming back to you, Rowan. I mean, just on Dave's point, he's sort of I suppose what he's really highlighted is the visibility of data. You know, making sure that the data that we produce is visible and accessible for people to use and to utilize. Can you talk about a few of the ways in which we're trying to make that data available and how it's being used?
Sure. So I think, you know, Dave, you make some really good points about how people can cherry pick data or can use a measure in different ways. And I think, you know, just not here at Turning Point or as a sector, it's about making, to me anyway, arguments where people understand what data they're using and the assumptions associated with that. There's no perfect measure. There's no perfect way to look at things. And in a way, more data, I'd argue, even though I'm a data person, is not always better. But understanding what that data means and what the appropriate context is, I think, one next step we can take. So yes, we provide a lot of data freely to the public through generous funding from the Department of Health. But maybe what we also need to provide is to say, how can you use this data best for you? And rather than cherry picking or taking particular stats, how can it work in local action plans? How can it work on a micro level to identify those groups that it needs to do so? So I'd say, that's certainly one way that we can work data better into stories, because this might be a frustration across the sector. I think too often we put up policies or suggestions that may not be evidence-based. And as a sector, we need to do better on that front as well.
Thanks, Ryan. I mean, I might just come to you on that in terms of, so obviously you're talking about data being used in that policy and research context. I can ask you in sort of, how does it translate into other areas of government like commissioning? Or what do you think the opportunities are with this data in terms of informing commissioning? We're going through a lot of reforms at the moment. There's a lot of other reforms on the agenda. Where do you see the role of data, and any advice around sort of what you need to sort of help you in that space?
Yeah, I was thinking about this earlier today on my way in, and, obviously that's a challenge for government, is to know, I mean, there's the influencing about getting the resourcing, and then there's the influencing about spending the resourcing, and then it's about spending it on the right things in the most efficient way. And data can't do all of that. Lots of people have to do that. And, it's government's role, it's the department's role, but it's also the community's role. And I don't want to get too weird about it, but, data is positioned in a kind of a big sort of social, environmental, technological kind of context. And the way you use data has to be informed by all those pressures. So it's not an easy answer, but, obviously there's ways that you can use data to show evidence of harm and need geographically, as we've seen, with great effect today on subpopulations that can help inform services and service planning. That's really important. And your points earlier about using data in different ways to show different things and potentially, informing it around services. There's potentially some really great applications of data linkage in terms of harms data, service gaps, and kind of really targeted planning. But there's always a challenge when you look at targeted planning. Your resources are never as much as you'd like them to do really specific programs. So I think the tension with government is sort of identifying, the harms data and then working out, your the way you prioritize harms, and data only gets us so far with that sort of with that question. But yeah, in the future, if we could have more ready access amongst service planners to harms data linked in with our service performance data, that would be really, really helpful. But then, of course, you have to be able to use it and have the systems around it to continue to apply it and kind of continually inform decision making.
Thanks, Amy. Chris, I just ask you, because you sort of have come from a sort of a policy research background in the alcohol drug space, and now sort of providing that sort of oversight of surveillance and interpretation. I suppose a couple of questions, so sort of any follow-up from Amy about how you see how the data could be deployed or used in a way that sort of enhances how government makes decisions in that space. And then secondly, our follow-up questions around, I think, the fact that it's you've been a strong advocate of making this national data. So where do you see the benefits of having this across all jurisdictions and nationally?
Yeah, sure. Thank you. And I should just preface, I don't have policy thoughts anymore. I've moved over to the AIHW and I'm not allowed to have policy thoughts anymore. I only have evidentiary thoughts. But I think there's some really important points raised by both David and Amy around the way that people use data. And one of the things that we've been very keen to do in my current role is to act, if I was to advocate for anything, it would be for the good use of data. And I was just thinking, hearing the other speakers, that data is in itself inherently neutral, but the questions that we ask of it come from a values framework, and therefore the answers that we seek in the data come from a values framework. And I think for those of us, sorry, for those of you who are scientists and students, it's often worthwhile to keep that in mind when you wonder why particular amounts of evidence have given rise to a particular policy, because it's not always done in a neutral environment, and that's, you know, that's fine. That's the way that our communities work. But in terms of in terms of helping avoid the cherry picking idea or the turning a blind eye to a particular piece of data, one thing that we've been doing over the last few years is data advocacy within the community. So again, I'll just give two really practical examples. We go out to Suicide Prevention Australia and we do 4 seminars a year for their membership base to talk them through what data sets are available, what are the limitations of these data, what can you or can you not say about these data. Someone might say, can I please compare these 2 points? And I'll go, no, please don't. You know, it's that. So trying to encourage people to take a more holistic view of the data rather than just relying on particular things that might speak to those values that they've brought to the question in the first place, rather than taking a step back. And we do also go over to the Department of Health frequently to give them seminars to help their policy people understand how they can help use data. So I think there's an emerging appetite, an increasing appetite, both within government, but within the advocacy sector as well, to make sure that people are having conversations with the data that actually align and support each other, so that there's actually a dialogue going on between advocacy and policy.
That's great. Thanks, Chris. Dave, just in your role as VAADA then, sort of how do you, in that context, I suppose, what are your thoughts about supporting the broader membership of VAADA in terms of how they use data, or other partners, you know, with VAADA and other key sectors? What are your thoughts there on how to use the data and how to work collectively together to sort of help address?
It's been really useful in that context. So, you know, we've had a number of our members, so funded treatment agencies, seek advice on collecting data and different data sources on stuff happening in their particular regions, perhaps before they meet a politician or even prior to an election and things like that, so they can put some content front and centre. And I've always been, you know, very willing to provide that advice and assistance in getting them a range of data sources, obviously including AOD stats, which has been really useful. Some things, and I know I'm probably going to put someone on the spot somewhere after this, but one thing which has always left me a little bit confused looking at the LGA data is Mildura. And I say that, and I know it's odd just to randomly drop that in, but Mildura has, for pharmaceutical opioid-related treatment, something like around 10 times the state average by way of rate. And I can't get a figure as to why that's there. So I sometimes get feedback from agencies, and I bring that up by way of saying, we didn't know this. You know, with regard to some of these data sources, but a lot of the time you go, that makes sense. It finishes the story which we see anecdotally. And I know Dan's going to rush back and get someone to say what is going with Mildura.
A lot of people ask that question.
So I might just open it up to the audience for questions. So this is your opportunity to ask all the things you ever wanted to ask of a policymaker or a policy influencer or a data custodian. Any questions from the audience while people are thinking?
I'll find the mic person, so I can grab a microphone from the panel.
Any questions?
Thanks, guys, for a very lovely talk and explaining things. So I think it's come to light that we can see the downstream effects of of data-driven initiatives. So I was just wondering, and we had talks earlier about data linkage. I was just wondering if there's any initiative to perhaps standardize some of these data sets across on a national level? And in terms of data linkage, is there a way that we can tie together different data sets? Is there an onus on that on the government and national level to just bring things together? Because if we can do that, there's more downstream effects that we can determine. And in doing so, yeah, I was just wondering if there's any perhaps eye on doing that.
I might throw it to Chris. Chris, I suppose is the promise and the
The answer to that question is yes. So yeah, I think you actually reminded me of the second half of Dan's earlier question around the nationalisation of the data approach. And so certainly one of the strengths of the work that Turning Point and the AIHW have been doing together over the last 4 years now has been to develop that standardised approach around the country. And I think the Turning Point team now get data from all jurisdictions bar South Australia and WA at this stage. And so it really is useful to have that common coded frame across the whole of the country, even though some of the primary records and the legislation that people operate under is different from place to place. So I think that's been a real benefit of the work. But in terms of the linkage possibilities here, I'm so glad to hear you mention that, because it's some of the things that we have the ability to do within agencies like the AIHW is to build bespoke linkages. I'm currently working on a few. If you want to catch up over, I always love to tell everyone about my data linkages, so come and grab me over refreshments after this is finished. But one thing I do want to work with Dan and the team is seeing how we can actually utilize some of the unit record data that they're collecting around the country, particularly in jurisdictions like Victoria, where there is actually really quite good data quality compared to some other jurisdictions, and see how we can actually link it to the hospitalizations data that people in Canberra have custody of, some of the death data that we have. And so we can actually start to see patterns of service use for individuals, and we can start to pull apart some of those phenotypes of service use that I think came up in the last batch of presentations. So that's a long way of saying yes and yes. And thank you for your question.
Rowan, I was interested to hear that you mentioned how important it is to contextualize quant data and having interest in qualitative research. I was wondering, is there much qual research data in the in this data set? And I was wondering the extent to which that's being kind of lent on to provide some of that context.
Yeah, look, thanks for your question. The answer is yes, in terms of some of the ambulance data we hold, not so much some of the other data sets, but paramedics in different jurisdictions can write quite a lot of information around a case to help contextualize what's going on. And I think we had a good presentation from Krista in the young men's anxiety space, but even in Anthony talking about some of the challenges around insecure housing and what's going on in a person's life at a particular time where they're seeking an emergency healthcare for a mental health presentation, which I think we'd probably all agree is not the ideal place to be seeking mental health care. So helping to use that qualitative information to contextualize what's going on can help fill that gap. I think it also helps tell a story, because ultimately we connect with stories. And in this afternoon session, we tended to stay away from just presenting trends and graphs over time. I mean, we can do that too, and that has a place in certain reports. But in this particular audience and forum, we wanted to tell stories, and I think qualitative data can do that well.
I think it's a great question. I might get you to comment on this and maybe Ray to Renee as well, because I think the challenge with this data when you don't talk about it is that the team of coders we have here do an amazing job. Read about somebody's worst day every day. So every day they're reading records of somebody's worst day, and so it just prompted me to think about we have really rich information. The paramedics are really great at documenting the histories. The reason why the data is so rich is because paramedics are very proud of the work they do, and they have very comprehensive notes, and that allows us to have a really rich understanding, allows us to create all these great variables of understanding what's happening. But it also speaks to sort of, I think, some of the challenges of pulling this data together. And I don't know, Rowan, if you just want to speak to the work you and Renee do in terms of supporting the team here and the work that they do.
Yeah, definitely. It's a good point about each one record that we get through, because they're all focused on AOD, mental health, self-harm is the worst day in someone's life. Often the cases that are read by our coding team appear on the news as sensationalist stories, and they appear in other outlets. And so the coding team that we have is remarkably resilient, and they come from diverse backgrounds, social work, nursing, psychology primarily, but there are others as well. And we have good frameworks to support coders. So Renee Webb, who some of you may have met, is our data coding team lead. She has a nursing background, and we do put in place a whole series of supports to help our team through as well.
Some of the qualitative data sets, I think that might tap into the question or is the qualitative data just left to one side?
Traditionally left to one side, but as you've seen today, is something that we have an acute focus on. There's been a few papers that have come out that the team has led, but I do think around the narrative I was saying around stories and around connecting both with funders, but also the general public, there's a whole lot more we can do in this space.
Just on that point, the department also accesses the ambulance data separately as well to sometimes dig into that where it's appropriate, to sometimes dig into some of that qualitative information, which we could never hope to do on a regular basis, which is why this data and the work that Rowan and the team do is really important, but we will dig into it. So for example, through our EdNav project, which people may have heard about, which supports the drug alerts that started a couple of years ago that my team developed. If we get an event that we need a bit more description about, or an admission in an emergency department that we need a little bit more information about, we'll often go into that data and just kind of see what's happening. And Dan, you're so right. Paramedics are so good at getting information out of people. It's really quite incredible. They're probably all novelists or something, but you can get really good information from people on the scene who might not end up in the ED as well. You might get, descriptive information about, a drug type that can be really, really helpful when we're thinking about whether something's identifiable or not. So yeah, there is a great amount of qualitative data in there, but it's really about sort of honing your purpose when you're going into that data and really being clear about what you're looking for, because there's so much of it.
Yeah, so I just wanted to add something around the qual data, and certainly it's something I'd be very interested to follow over the next little while you guys investigate this. If you have a look at some of the work we've published on the suicide and self-harm monitoring site, we've actually been working with the ABS to go in and code psychosocial risk factors that they draw out from the coronial records. They go through the NCIS case by case and code history of relationship breakdown, for example, survivors of child sexual abuse. And we're able to report on all of those by various demographics and give a sense of what's going on in a person's life besides the acute event that we're recording. And it actually is very, very powerful. So yes, I'm looking forward to that.
Thanks, Chris. And I think the point I was just going to make, one of our previous sort of senior leads in the team, James, sort of did a paper looking at opiate overdoses, and I think where the data is really useful, he did a qualitative look at the sort of the stories, and I think the narrative is that when people overdose on opiates, it's generally because either it's accidental or an unintended. But what he saw in the data, particularly for prescription opioids, was that people were and then this is the interesting for you, Chris, in the whole, we've had these discussions around suicide intent. So that people weren't suicidal, but they were so distressed with pain, either physical or emotional, that they really didn't care what happened. So they were taking more of their medication to sort of numb that pain. And I think it doesn't count in suicide stats, but you know, there's very, very interesting, that whole notion as we dig into sort of qualitative experiences of people, you know, who end up, you know, in harm's way, sort of how we classify those.
We were actually having a catch up over lunch, a small group of us, about this particular concept. And it was sort of like we can identify intent, and we can identify non-intent, and we can identify unidentified intent, when often what we're dealing with is actually deep ambivalence to life rather than any of those categories.
Thanks, Chris. We've got time for one more question. Thanks, Ellie. Any more burning questions?
Thank you. In the previous session, the data that has been, the use of the data has been primarily discussed in the context of descriptive analytics, as far as I understand. So the use of data to understand patterns and so on and so forth. I was wondering whether this data set is planned to be used more in the predictive sense for running predictive analytics model, and potentially for prescriptive analytics as well, something like simulation-based optimization, modeling, et cetera, et cetera. Thank you.
I think it's a great question. Do you want to take it, Rowan?
Sure. Yeah, great question. The answer is yes. And so there were some, you know, interrupted time series shown there, looking at changes based on particular policies or times that are evident. So there's a whole place for inferential statistics in the data set. Some of the series that we have do go back to the late 90s. So there's a whole time series that, you know, can be investigated depending on the question of interest. We also have been building, you know, I guess more complex multi-level models using quantitative data. So happy to catch up if you're interested in any of those questions and talk about where the team's taking it. Today, the remit from senior staff here was limit the data. So we wanted to keep the stories accessible, but most certainly there are more complex inferential stats involved.
We might just finish this by going through the panel, just ask any final comments. I might start with you, Amy, but so I'll just give you a minute to get your thoughts together, just in answer to that. So we've done quite a bit of work with the faculty around looking at AI, machine learning, modeling. As you know, the predictive modeling space is the, I suppose, the holy grail. And we have made some attempts at doing some modeling, but yeah, love to catch up to hear your thoughts on how we can refine that. I think it's a very exciting opportunity, and we, as Rowan said, there's so many data points over such a long period that it'd be great to look at sort of what that could look like. So I might throw you to Amy. Any final points?
Yes, maybe science fiction. Because what I was thinking was, you know, looking at how we use this data and sort of, you know, predictive capabilities got me thinking a little bit about, you know, what I was saying earlier, about there being this data being in, you know, the context of social and community and technological sort of change, and thinking about what's the future for this data in a world where health service delivery looks different, where health-based technologies are collecting more and better information. So could we, science fiction, be in a future where paramedics are not just quizzing people on their lives, but are also doing like on-the-spot tox, and that data is flowing into the system. So yeah, I'm just, I guess I'm putting it out there that I think, you know, sometimes we tend to think about how can we improve the data set in terms of its optimization, its technical optimization, but I think there's a bit of work for us in thinking about if we want this to, you know, be a few, you know, maintain this data set into the future, what should we be advocating for in terms of the, you know, the surrounding technologies and services to really help us learn more about people and the way they present to services in need.
I might move out of the science fiction realm. It's probably a bit beyond me, but you know, on a practical level, I think having more accessible data snapshots for particular regions. So an agency can go, I'm in Ballarat, I need to know all the top-notch data, and there can just be somewhere to trigger that straight away so they can see that. And the same for policymakers and so forth, and people in other sectors who may find it a little more complex to understand. And I guess the other thing, and maybe drifting towards science fiction, so I probably lied, would be seeing things more so in real time. I know that there's obviously pressures on that, and coding and all that sort of takes time, but you know, we are often talking about yesterday and trying to make a recommendation for tomorrow.
Thanks, David. And I might just follow on from that theme, because I mean, the timeliness of the data that I was going to start by saying everyone in this room who works on this material should be very, very proud, because as I do note whenever I'm talking to international audiences, they go, you have what? you do what? So no other country has anything that even remotely resembles this, which is why I am committed to continuing to be world leading. And we will build those linkages, we will build those regression models, and we will pull that stuff apart. But just in terms of building off the timeliness comment from David, one thing that we have been doing with other data sets and some very clever researchers at the University of Melbourne is looking at spatio-temporal clustering of fatality events using coronial data. Now, I wanted to see if we can get ourselves into a position where we can amplify those signals by looking at non-fatal events to help find those kinds of community events earlier, quicker, and intervene in the communities more quickly. And I think it will take time, it will take years, but I think we'll be able to do it. It may sound like science fiction, but I assure you it's not.
Thanks, Chris.
Yeah, I think, Dave, you raise a really good point about timeliness of the data. And I think, you know, every day we want more and more information to be timely. So AI has a role to play there, and taking some of the simple cases out of the system so they can be coded automatically to give our wonderful team the majority of their time and cognitive power to focus on the more complex cases is one area where that could happen relatively soon. But of course, I'm going to have to finish on science fiction, given that that was the theme of the final question. One thing we haven't discussed today as a panel is the paramedic workforce. And I think the data set also houses some really useful information for education and training of paramedics. Now, they have these wonderful rooms that are set up like virtual reality with full ambulance and scenarios that they run their teams through. And I think that this data can contribute to training them so that they're upskilled, they feel confident in dealing with things like anxiety, depression, and overdose, and empower them as a workforce. So I don't want them to be forgotten, and that's my science fiction finish.
Thanks, Rowan. So we're on time. I just take this opportunity just before I thank the panel to thank Rowan, Renee, and the brilliant team who put an enormous amount of hours to code, as Rowan said, up to 1 million records a year. That's an enormous effort. As we said, it is very challenging data. So I know when we get asked for data and the timeless of data, it's understanding sort of how much effort and the amazing work that the team does here. So a big thanks to them. And none of this data would be available without their hard work. But thanks to our amazing panel, Amy, David, Chris, Rowan, put your hands together. Thank you so much.